Good morning, good afternoon from everyone who's joining online and in person. Welcome to our first Health and Wellbeing session at the Resilience Hub, building climate resilient health systems through locally led adaptation, Voices from the Ground. So I have the pleasure of introducing our session today. My name is Amanda Quintana, and I'm here with London School of Hygiene Tropical Medicine and Abt Associates. Our co-host of this session today is Abt Associates, Health Systems Global, South North, and WaterAid Bangladesh. So the way that the session is going to run today is a very interactive session. We're going to have a moderated first half of the session, hearing from experiences of our speakers, and then open it up to the audience and those online for an interactive Q&A and discussion. So health systems, which are comprised of all organizations, institutions, resources whose primary intent is to promote, restore, and maintain health, face climate change impacts, and they must build resilience to protect and sustain the health of communities and people. Applying lessons from past responses to shocks and stressors are critical to experience resilience, especially in the health system that relies on the coordination with various sectors and governance levels. So today we will hear how community level activities from health systems strengthening resilience, locally led adaptation, as well as examples of indigenous and community-led interventions have created opportunities to improve the health system's resilience and the ways forward of embedded community-led actions and principles to build climate-resilient health systems. So I'm welcoming our speakers here in the room. We have Dr. Tabinda Sarosh from Pathfinder International, the President and Chief Innovations and Engagement. We also have in the room Pagta Hifas Sheikh, Director of Programs and Policy Advocacy at WaterAid Bangladesh. And online, virtually, I don't know if we can get them up on the screen, that would be great if we could. Online, we have Dorothy Maroki, who's representing Abt Associates ICANN project, the Integrated Health and Nutrition and Agriculture. She was the project's chief of party. Dr. Lawrence Babao from Eastern Technical University of Sierra Leone, and Dr. Carol Zavaleta from Universidad Peruana Cayetano Herida, a researcher and fellow. And so I'll hand it over to Dr. Tabinda Sarosh to lead our discussion. Thank you.
Thank you so much, Amanda. And hello to everybody sitting here. I hope soon we'll have more people listening to us, but we're also connected right now online with several of our participants. Welcome. I come here from Karachi. I represent Pathfinder International, and last night I was thinking around how I would start this conversation, and something that comes to mind and what I wanted to invite all of you to think about are two scenarios, right? The first scenario, if you just close your eyes maybe or your mind eye for a minute and think about acres and acres of land flooded, and think about campsites and 625,000 women in these campsites are pregnant at the moment. Now imagine that 75,000 of them are going to be delivering in the next 1 month. And the campsite still does not have enough facilities and equipment to be able to respond to that. Now let's come to the second scenario, right? 2 schoolgirls leave their school in Sylhet to go back to home, and they hear the cyclone alert. And they rush to the community shelter home, right? And where their family is most probably waiting for them because everybody's gathering at the shelters. And what happens is that both of them are on their periods, right? And they would run to the shelter. They end up spending 3 nights at the shelter without any provisions. And they find a corner in the shelter home, and they just stay there. They're not able to talk to their mother or any other person from the health systems at that time who could provide them with some guidance around this. One of them ends up with a complicated urinary tract infection after the 3-night ordeal. Now I want you to come back and know that these are not artificial scenarios. This is not a simulation, and this actually happened last year in Pakistan and Bangladesh, simultaneously where Pathfinder works. So Pathfinder is a global organization that has been working on women's health, particularly reproductive health, for the last almost 70 years. But for the first 50 years of our work, it was very much focused on family planning. But the insights that were coming in, from the communities, from women and girls, is that pathway to a women's health and girl is not a singular pathway. It's multidimensional and it's very nuanced. And hence, Pathfinder for the last 15 years has been taking a multi-sectoral and multidimensional approach towards women's well-being and health. So, of course, with the support of our donors, since we are a non-profit organization, donors like the Vodafone Foundation, Jane Goodall Foundation, USAID, Takeda Pharmaceuticals, and climate philanthropic donors, we've been programming in Tanzania with school children to be able to convey and raise awareness and agency around climate resilience. We've been working with health facilities in Bangladesh and Pakistan to assess their readiness and preparedness for the shocks as well as the insidious stresses that climate change presents. In addition to that, we work in Pakistan with community-based organizations and women champions, who are the custodians of the wisdom around climate resilience for a long time. And we'll talk about that in our panel today. Carol is joining us and there she is. Hi, Carol. Hi, everybody. I can see on the screen now. And so, we have a great star-studded panel here who's going to be talking about their experiences in the field around different elements which kind of make the health systems. At the center of it, we have the women and girls, but then come the communities, the health systems themselves, the middle management, the frontline providers and workers, and then the policy makers. And today, some of our panelists are going to talk about their experience on that. So, in addition to that, just one last thing is that how do we talk to the health systems themselves to become more eco-friendly? So in Egypt, Pathfinder works with the government of Egypt to convert the facilities into eco-friendly facilities. We call them the green clinics, where we are introducing eco-friendly water management frameworks and protocols, as well as waste disposal and alternate energy sources for the health systems themselves. For contexts like ours, Pakistan, Egypt, Bangladesh, this is relatively new, and it would require a certain amount of climate financing and health financing to take it through. So, hi, Amanda, would you like to say something?
Yes, I would be remiss to also mention that we have Rohan, our cartoonist, online, who will be drawing some cartoons based on the discussion today. So apologies for not having made the introduction. Rohan is on the screen as well as Dr. Susanna Mayhew, who's representing Health Systems Global. Thank you.
Yay. So without further ado, I think I'll actually would like to start the conversation with Lawrence. Just to let you all know, we are very cognizant that not everybody here is from the health sector or listening to us online, so we'll try to keep it as jargon-free as possible, and also to do this as conversationally as possible, right? So, Lawrence, I turn to you. You're my co-panelist joining from Sierra Leone, and I just want to backtrack a little bit and go back to your experiences and insights, that came from the Ebola crisis in Sierra Leone, where you were working with a lot of groups of people, to understand where the health systems were failing and what was working, what was not working. And so over to you, Lawrence, to share some bits.
Yes, good morning, Tabila, from my side. It's still very early here. It's about 6:30 in the morning. But then we go on. I'm going to look at this activity from maybe three perspectives. First and foremost, it would be good to know the general understanding of how the Ebola outbreak actually played out. It will also be good. The second part of it will be to look at the lessons that we have learned during the response, and then lastly some recommendations for future outbreaks. First and foremost, I want to say that the Ebola outbreak in Sierra Leone and also the sub-region of West Africa actually revealed the systemic inadequacies in the health system and the shortcomings of global pandemic response capabilities. So that was very clear. Beyond the community level, the culture of the response itself severely limited effective control. And by June 2014, for example, there were about 60 locations across West Africa where the Ebola had been discovered. Consequently, much of the blame for this kind of trend was directed at the architecture of global health governance, specifically the WHO. Even though the organization should have seen, given its mandate, leading the response, the agency initially downplayed the scale of the crisis and then dropped the ball. This trend of affairs exacerbated kind of the response. Another issue that we need to know actually was the poor communication during the response. Poor communication, delayed logistics, bureaucracy, there were a lot of bureaucracy and difficulties negotiating with partner countries and organizations, especially by the African WHO office. And that meant that it took about, for example, 8 months before the first confirmed case was actually brought to the light. We also realized that perhaps more acutely, the Ebola crisis also exposed the health system in Sierra Leone. We realized that the existing policies on surveillance, for example, and outbreak response only existed on paper. But we are rarely known outside a small cadre of technocrats in the capital city of Freetown. And in fact, these were haphazardly implemented during the times of the crisis. Even before the virus hit, there was a tenuous shortage of health staff. Sierra Leone and Guinea, for example, ranked at the bottom of statistics in terms of doctors per population. Hence, a medical service relied more on the aid industry, which funds and manages a significant number of hospitals and other facilities. There were also chronic underfunding and neglect, which contributed to health systems of Sierra Leone effectively being vectors of the Ebola. The lack of essential infection and control materials and training created dangerous circumstances where health workers had to triage and isolate suspected patients with substandard resources under duress. This scenario contributed to further spread at clinics. Clinics were then shut down and healthcare workers fled. Further, there were also substandard care.
So I think we'll get Lawrence back very soon, but something that sets us thinking is around the challenges we have around communications, right? Hi, Lawrence, I think we have you back. Go ahead.
There was also some substandard care, like the socio-political trends, which provided little ground for trust between clinics, public health authorities, and communities. Communities are often seen as passive recipients of biomedical knowledge, an idiom that perverts local understanding and obstructs ways to involve local people in meaningful ways. The other thing that we also want to talk about, that which played out clearly, was the community engagement, which suffered from a lack of dialogue and multiple layers of mistrust between the government, response agencies, and citizens. From the beginning, state communication was mostly a one-way street, and messages were confusing and
we'll come back to Lawrence again. But I think what I really caught in this conversation was the lack of communication. And this lack of communication was not just between the communities and the systems, but the various... Hi, Lawrence, we'll just come back to you. Yes, hi. Lawrence, we just have another panelist who has just joined us, and we'll just be right back with you. But one thing which we wanted to move towards is lack of communications between the multi-sectoral systems themselves. Because what we have seen, how women and girls are getting affected, it's not just their access to health, but their access to education, child and forced marriages, water and food insecurity that happens at the same time. So Dorothy, you're joining us from Uganda, you know, and when I was last talking to you, I was very fascinated about the different multi-sectoral approaches and community engagement approaches that you talked about, taking an integrated approach to in times like this when we need to build climate resilience and crisis resilience. So may I just invite you to come in and talk a little bit about that right now.
Wonderful. Thank you very much, Tabinda, and wonderful to be here. Looks like there's an echo.
Wonderful to have you.
All right. Yes, so as I'll draw my examples from in this discussion that is so key of building climate resilient health systems through locally led actions from USAID's Feed the Future Uganda, Integrated Community Agriculture and Nutrition, the ICAN activity. I'll use the acronym as we go on. And I'll just share some examples of how we saw this intersection and at the same time make some recommendations from our learnings. So, as the name infers, ICAN was integrated across sectors with a focus on increasing opportunities for poor and vulnerable households and also improving nutrition, especially among women and children, and also strengthening community and local governance for resilience. And this work was implemented for 5 years through July 2023. So during the implementation of ICAN, there were relevant climate change shocks and stresses, and these included, relevant for this discussion, and these included drought, there were delayed rains, there were floods, and these led to food insecurity and malnutrition, among other challenges, such as varied exposure to health risks and displacement. Now, an example that highlights the intersection between health systems strengthening and climate, and therefore our contribution as the activity to build a climate resilient health system through community engagement, is that we used a multi-sectoral approach to build the capacity of frontline primary healthcare support. And in Uganda, these are village health teams. In other geographies, in other countries, they can be community health workers and so on. And we supported them to gain and improve their skills in food production through on-site establishing of backyard and perma gardens for nutrition, and also creating their awareness about the environment and the value of tree planting. Now, the VHT supported mother care groups, and these were groups that brought together and reached out to pregnant and lactating mothers at the household level. And through the VHT support, as they built their capacity, households were able to establish their own gardens of nutritious vegetables, and they planted high-yielding, short-maturing crops, for example, iron-rich beans, green grams, or mung beans, and these were both for consumption and market. This effort was supported by local private sector, especially the market, taking product to market, and also the National Agriculture Research Organization. So that means that alongside VHT's traditional role as community health workers for tracking child nutrition and the well-being of pregnant and lactating mothers, malaria, HIV, etc., they now had additional skills and connections with, for instance, agriculture extension services, through what we termed in the activity business service providers, and also local private sector. So they were able to offer health support in reducing the patient burden at the local health facility. But at the same time, they were playing a crucial lead role in diversifying economic opportunities and climate-smart livelihoods of households, which therefore had a direct correlation with health. So we can see that those are two sides of the same coin. Now, these strategic collaborations and connections and partnerships, being locally led, were sustainable. And in our work, from our data, it led to reduced cases of malnutrition and a stronger cross-referral system within our geographic reach. And in this way, the integrated programming and the effect of breaking silos contributed to the health system's resilience. Now, additionally, the health system players were enjoined in the strategic behavioral communication effort that we had, and our messaging covered health and the and other core resilience actions such as water and sanitation and health wash, and nutrition, as I mentioned, environment, livelihoods, and community participation in government, in governance. Now, it's clear that there are new needs that emerge within the health system due to climate change. And I'll just focus on a couple that I want to bring to this conversation. It is imperative that we need to build knowledge on the interrelationship between health and climate change, and not in boardrooms, but at the community level, so that the VHT, the village health team member, the community health worker, the health service provider, they are aware, they are knowledgeable about the correlation. So that means that traditional roles where, for instance, these healthcare workers are very specific on their clinical support and so on, and primary healthcare, they will need refresh for both actors, both health and climate, so that we are able to leverage resources, both people, financing, and knowledge. It's also, we note that, health service providers, especially community health workers, they interact directly with the community. And so from our lessons, from our learning, they are actually viable agents of change to concurrently support the health system resilience through playing a role in climate adaptation actions and bringing their community representative voice to the decision-making process. I mean, they have direct contact with the household and with community. And this representative voice is all the way from design to execution and tracking the actions. Now, to do this effectively, they do have to understand the interplay between the climate shocks, risks, and also the health system, so that in that way, this breaks the silos and addresses the disconnect that sometimes is evident between health systems strengthening and climate. So, given that these are key community existing structures, this working together coordination, as we learned, and that's a recommendation that I bring, is that it will ensure there's a shared purpose between all the players in health and climate. There's commonality of action and messaging, and the strategic communications is very important. And when there is that commonality of action, then this becomes a really strong bedrock of advocacy for health services, and therefore health system strengthening, and also climate adaptation actions. I dare say that we cannot overemphasize the need for an integrated and multi-sectoral approach and the building of trusted local collaboration and partnership. And of course, this will be leveraging on ground level and that's the focus, that it leverages on ground level community learning, which includes community level data for decision making, so that there is a feedback loop in how things are working, how the health system is being strengthened, what are the gaps as they become evident, what are the root causes, and this therefore will be therefore becomes a concrete effort and contribution in as far as building a resilient health system that is locally led. I think that's what I'd say, Dr. Tabinda. Thank you.
Thank you, Dorothy. And so well said. And Dorothy talked about integration for climate and health to be talking to each other. So isn't it great that today is the first health day ever at a COP anywhere? Can we have a little energize? So thank you for that, Dorothy. And you know, Dorothy, one thing that you reminded us of, all of us, was around the knowledge that stems from the communities, how important that is. You know, yes, we know we have the agents of change as the frontline health workers, but the knowledge itself is stemming from the communities. And that's what takes me to Carol. Carol, it's so good to have you here. And you've been working with the indigenous communities, you know, and you've been building your experiences and designs based on the wisdom, you know, which comes from centuries-old experiences that communities have around, you know, around living with nature and living with their climate. And I was specifically looking forward to your talk in this session. So, if you would also like to talk a little bit about the experiences you had during COVID-19 and how the indigenous communities, you know, came about to deal with that. Thank you, and over to you.
Thank you, Tabinda. Thank you for the invitation to this Resilient Hub. It's really very nice and very honored, and thanks for the opportunity. And so yeah, thank you. So I'm now in Bolivia, but most of my work has been in Peru, in the Amazon, for the last 15 years, working with indigenous communities. And today I want to share with you all about 4 main things. So I want to share about the importance of recognize how South America is a multicultural region. I think that's very important to start this conversation, to recognize that as a region where many cultures are living together, even if the cultures are not, sometimes we say that we are minorities, but in general, we are multiple. The second thing that I want to expand more about in later is how we observe communities were responding to COVID-19 first, and based on that experience, we implemented another study to understand how was the responses of communities to specifically to climatic hazards. The other thing is the importance of the learning process of the health systems, in particular in Peru, where to understand how indigenous communities were working on health and climate, and also how the health systems can articulate it with indigenous communities. And finally, about the importance of indigenous knowledge, as you were mentioned in the room. So I was mentioned about these multicultural approaches. So we recognize that we are a multicultural region because when we understand that we are multicultural, we can see that our understanding about health, about what it means, the healing process, how is the healing process, and how we approach the risk and the shocks is different. And for example, you want to talk about how women, men, children, and elder cope with risk, we need to understand that not all cultures approach in the same way. And I think this is very important for example, the health workforce to see these differences, and also for our leaders to recognize these differences, to try to create this articulation across cultures. So there are more than 8,000 different indigenous populations in Latin America. So that's a lot, and I think it's important to recognize. The second thing that I want to mention is about how we observe the community resilience, right? So during the COVID pandemic, we implemented COVID observatories across 11 countries in the world, and one of the countries was mine in Peru. So in that, during those for 2 years, we observed how a community, especially the the indigenous organizations, how they were well organized actually to, for example, manage the communication system across the country, from the national, the regional, and also the community level. And what is important, this communication, exactly for what Lawrence would mention before, right? So to handle the risk. So how do you understand the risk? Not only because of COVID, for example, or the emergency during the climatic event, it's important, but also how they perceive the risk, if they're going to feel the fear, if they're going to understand what they are going to do. And also because the language, because we are so multicultural and we are so different, there are different languages. And if there are different languages, so my country, our predominant language is Spanish, but there are more than 40 different languages across the country. So these indigenous organizations were particularly important to manage all these information. So when we were working in these COVID observatories, we were actually having monthly meetings with indigenous leaders in 2 regions. So they were reporting how they understand the risk. And we had the opportunity to create like not an official training, but we were able to create like a communication systems in terms of clarify fake news, for example. So in this way, the indigenous leaders can transmit a better information to their community. That was their idea, to implement a broadcasting program in their own language, just to communicate about this risk, to invite, for example, teachers, health workers, priests, to speak with the community. And so when we saw that during the COVID pandemic, we then applied to the Alliance from WHO to create the other thing, that is how the communities approach climatic shocks. And this is when we learn about specifically how the community use the indigenous knowledge in 3 main ways. So first, this was about the use of medicinal plants and also treatments. And these treatments and medicinal plants usually are overlooked in the system, in our health system, because we rely more on biomedical responses. But during our question for the communities were, how did you handle the last emergency, the last climatic shock, for example, flooding, or a cold wave, or a strong wind? So they identify the climatic hazard, and they say, okay, for example, during the flooding, it's usually that the snakes go around because everyone wants to look for shelter. So snake also. So there are more cases of snake bites, for example. So they know how they can handle this patient, and they wait. I mean, they are waiting. So this is the part of maybe preparedness, when they know what would be maybe some potential health risk during these extreme floodings. So they have these particular plants. We don't know exactly the names because this is part of the indigenous knowledge. And the second thing that we have learned is that also they have these sharing networks. When, for example, there is these flooding events on extreme moments where they cannot access the crops, they rely on the sharing networks, sharing for food, sharing for shelter, sharing for shelter, and sharing for seeds, for example, for the recovery periods. And the second lesson of this information is that for them, the health systems is not only necessarily focused on just the health aspect, but also what Dorothy was mentioned before, right? About food, about water. So health system, or health in general, is not only seen as one particular thing. It's many things at the same time. But at the same time, what we have learned in this study is that for the health workers, because we work with health workers and also with indigenous communities, for most of us, when we are health workers, because I'm also a physician, we see health as part of diseases, of a part of programs. But for the indigenous communities, health were more related with actually the water, the food, the air, the river. So they didn't mention specific diseases. They mentioned more about what is happening in the environment. So that's also was important for us to see how they see the health system, not only focus on the people, but also in nature, so in the elements on the environment. And finally, the last thing is about how the learning process on the health system were. Because when we were working with the health workers, and we transmit this information from the community to them, and also to try to create a working table in Peru to create these spaces where we can bring the information. Actually, the community in this online table, they can share the information from the community, and the health worker, they were aware of we have indigenous communities, we have policies that we can that recognize that we are an intercultural country, but actually there are not enough like knowledge, capacity, and training to be welcome with this indigenous knowledge. So these articulation spaces, we still need to work more hard to create these spaces with the biomedicine, the health system that is more biomedical oriented can work together with the indigenous knowledge for supporting preparedness to cope during the risk, and also for the future for recovery process. This is what I want to share. Thank you.
Thank you. Thank you so much, Carol, and thank you for reminding us, about how the knowledge of the communities is so essential, and this marriage of modern biomedical approaches with the indigenous knowledge and wisdom is very important. And I think Carol also talked about the difference in cultures and the way communities engage with different kind of disasters and situations, and that kind of makes me want to come to Partha, because I know your experience in Bangladesh has been with rural communities in rural scenarios and health systems responding to them, as well as the urban experiences. And yet there are the coastal communities whose experiences and the systems experiences is very unique there. So if you would like to tell us a little bit about that. Yeah.
First, I'm Partha. I'm from Bangladesh. I work for WaterAid. A little bit of WaterAid. We are, and as she was saying, that this is the first health day. So water sanitation hygiene organization doing in a health day. Definitely we see the linkage between water sanitation hygiene and health in terms of many things. So WaterAid basically looks into, as I said, water sanitation hygiene so that everyone everywhere can access it by 2030. We in Bangladesh have engaged with the health system in a multiple ways, So just to give you an example, and the viewers were online and also here, how the health system in Bangladesh works. In Bangladesh, there are the community clinics at the very grassroots, which caters to around 6,000 to 8,000 population. And then within, above that, you have this Union Health Complex, and then you have the Upazila, and then you have the bigger kind of tertiary health hospitals and colleges, all that. So as you can see, we work with the community clinics at the very grassroots. And as she was saying, and as the other panelists were saying, issues of accessibility, poor communication, IPC, all that matters. So just giving you a couple of examples of what we did at the various geographical regions of Bangladesh. So up northeast, if you look at, that's the perennial wetlands we call Haur. And there where we supported the community clinics to have, clean water, sanitation, and, hand washing facilities. And the way that our community clinics are built, you can also, there are scopes for babies to be born. So, but if you really want to do that without the access of water, hand washing facilities and all that, it's not even, it's not thinkable. It's unthinkable that if you don't have all this, how can you really have babies born there, woman giving birth to children. So we basically supported, community clinics to have better water sanitation hygiene facilities. And there are 2 rooms where there is one labor room. So the latrine, the toilet there, it was upgraded. Separate toilets for men were created. There was a space created for people to come in and, when they are going to talk to the community healthcare providers, so that they can wait. And interestingly, what we have seen, as I was saying, up north, northeast in the Howrah region, where there has not been any birth in those community clinics, once they have the access to water, sanitation, hygiene, women are, secured enough so that they can come to there and give birth. And I was there in one of the inauguration of this, clinic there, and the civil surgeon, he was there. He was inaugurating that, and the traditional birth attendants, who are basically, or the skilled birth attendants that we, if they're skilled, we call them skilled birth attendants, is, and she was sitting in front, and we were all, in the dais, and it was an opening session. And within that, there was a discussion with the community and everything. And interestingly, the community health provider introduced everybody to the, civil surgeon. Mm-hmm. And immediately, the skilled birth attendant said to the civil surgeon, "Sir," basically, the discussion was started by the civil surgeon, that now you have all this, so you can, deliver babies here. And she just immediately said, "Sir, I do not," and by the way, I'm not a physician, so, and she was saying a lot of technical terms in terms of what kind of instruments that she would need. And you see the thing that immediately happened, and, he just instructed his, subordinate that when I go back today to the office, remind me that, I have bought all this, and I need to send it here. So you just see, having access to water, sanitation, hygiene, and you talk about policies and all that. Yeah. And if the policymakers or the people in power who make this decision can know about it, immediately situations can change at the grassroots. So this is the way that, we as WaterAid try to work, where it's not only about, building or developing that health systems, that community clinic with water, sanitation, hygiene, but also linking it up with the, the policymakers, the decision makers. The other thing that we do, there is a management committee. So you talk about locally like adaptation or local actions. So the management committee of those, and we understand that, you just can't develop or build or upgrade a water sanitation system in a health system and just leave if you do not strengthen the operation and management or the maintenance of those systems. So there is where we get in, and as I was saying, the lowest level tier in Bangladesh in terms of administration is the union, and the Union Parishad chairman, and there are women members. They are also part of the management committee for that community clinic. We get them on board so that they know, and remember, these are all political entities. So basically, it's there for their own kind of political influence also. So they get into the act to manage that. So that's one part of the story there. And it's also, when you talk about climate change, we're in COP, so basically how is, that relates to climate resilience and all that. Definitely, where we can, the solar system, solar pumps and all that there. But particularly when you talk about climate resilience in terms of health systems, I would rather talk about the coastal belts, as you were saying. There we do the same thing, but the twist is rainwater harvesting, because all the water is basically saline. So we put in health, rainwater harvesting systems there when we, when we want to talk about water, sanitation, hygiene, clean water. So, it's filtered. We make the filtration process there so that they can have clean water in the health systems. And again, as I was saying, it's about the operation and management, maintenance of it. the management of it, so getting in the Union Parishad and civil surgeons alike into the systems. I was hearing about Ebola, and somebody also was talking about COVID-19. And as I was saying, what is a water sanitation hygiene organization doing in a health system? In COVID, hygiene was the thing. You have to wash your hands and all that. So basically, in Dhaka, in slums, we promoted hygiene appa, which we call them hygiene sisters, who went with the mics and everything, so people can wash their hands and all that. But as I'm saying that to hurry it up a bit, in the policy level, what we did is two things. One, I'll tell, for the community clinics, we tried to influence the health system authorities to devise a guideline for health system wash guidelines for the community clinics, and also particularly for the strategy in terms of how we address COVID in terms of water sanitation hygiene.
So isn't it amazing that you were actually engaging with people who are not public health practitioners directly? And I think that's very important, because as a public health practitioner, I would like to see more of non-physician types, right, to be talking about women's health and girls' health. And one of the key areas here to connect is also the transportation, because, through the effects of climate change, often the access to the health facility is impeded. And when Pathfinder, with our work in Tanzania, we are actually transporting women and girls in emergency reproductive health care needs to the facilities themselves through a project called M-Mama. You might have heard of it. Very recently, the president just announced that she's going to be scaling it up to the rest of the country. But for that,
the infrastructure that we develop, or these are persons with disability friendly, because all the latrines and even the ramps. So these are absolutely needed in terms of when you talk about health systems.
Absolutely, I totally agree with you. But for that, you did mention policies, and for that we do, at the end of the day, do need policies, do need frameworks and implementation guidelines. And we are very lucky here to have Charles. Your introduction was done by Amanda in absentia when you were not here, and we would love to hear from some of your experiences in Kenya around navigating these multiple levels of governance. Need of data. I would think data is going to be very important, not just from health, but from different sectors, to come together for that kind of policy work. So over to you, Charles.
Thank you very much. My background is on environmental science, and I'll share the perspective from this question. Do we have conventional or modern or indigenous health resilient systems in Africa, for instance? Do we have integrated modern and indigenous knowledge health system or resilient systems currently in Africa or elsewhere? Those are fundamental questions that are going to help me in terms of contributing from the organizational Africa Research and Impact Network's perspective, but also from my personal experience as an environmental science graduate who went to Dadaab refugee camp in Kenya, one of the largest refugee camp, and requested to join the public health team as an environmental sanitation volunteer, and later on went to the district public health office. When I asked to join them as a volunteer, they asked me, "You're not a graduate of public health." But I knew that, I had confidence that I've taken some courses on public health, but finally they admitted me, and I competed, and I found there is a linkage between environmental concerns and public health question. So Africa Research and Impact Network, this has a membership of 200 research fellows from 36 African countries. We have our executive director here, Dr. Joanne Satella, and it's a multidisciplinary focus. So from Africa's perspective, what is the policy framework? There are overarching policy frameworks in existence which are shaping especially the data question.
Yeah.
We have the Libreville Declaration on Climate Change and Health. We have got the regional strategy for management of environmental determinants of human health, that is 2022 to 2032. The framework of public health adaptation to climate change in Africa. But the main question, how are these regional framework catalyzing or motivating the implementation of health perspectives within the national determined contribution at the country level. Now, our colleagues have mentioned the sectoral, and we are currently ongoing with a study funded by Wellcome Trust. Africa Research and Impact Network is leading, jointly with the African Population and Health Research Center in Kenya, but we are focusing in Africa. And one outcome is there is fragmentation in terms of organizations. Yes, there are specialized individuals, institutions, but they are highly fragmented, raising the question of bringing this polycentricity. And secondly, raising the questions around, are there synergies? And that is what we are trying to unpack. So we have 3 webinars. And the key thing that my colleague, the moderator, has brought in is around the data. We have got the national data systems, institutional data systems. What are the data collecting frameworks or tools that we have used to collect those data?
Sure.
And for those who have experience, especially with the vulnerability assessment, currently we have got close to 719 tools, but have they gone beyond piloting? And that brings in around the contestations and conflicts around state-driven and non-state-driven and community-led driven data. Because when you say that something is happening here, the community might say, no, it's not happening, or the government might say, or the NGOs might say this. But if you look at the context, like for instance, Kenya and I right now in East Africa are experiencing El Nino. When the National Disaster Operations Center was commissioned and they were sharing the data, whose data? No, first, who collected the data? And whose data are these systems sharing to inform policies? So it comes to the second question, or the gap around the co-production. That is the need to co-produce the data so that we can have analyze and co-produce evidence. And secondly, in terms of knowledge, translation, and brokering platforms, do we have vibrant platforms in our context? And I'll share with you that currently there are evolving platforms at different levels, both at the regional and national and the sub-national level. And especially at the community level, they are using especially the indigenous knowledge sharing and engagement systems. The question is, are these platforms integrated in such a way that there'll be communication from data that has been collected, but also if there is feedback? And lastly, in terms of research agenda, have we shaped a common research agenda in Africa on climate change and health? And that is a question for another day in terms of debate.
Indeed.
But from where I stand and from the discussions we have had over the last few months, it's quite difficult to co-produce a common research agenda when there are no common tools for assessment and common platforms for analyzing, archiving and analyzing relevant data. And that is going to be a very key challenge in terms of developing a common climate change and health program for Africa, and also leveraging adaptation financing. So lastly, my colleague mentioned around multicultural aspects. One delegate at the Africa Climate Summit raised the question, who does the intelligence around the impacts of climate and on cultural issues and traditions on what we contribute at the policy spaces? And that is a question I'm leaving for you to respond to. Thank you very much.
Thank you. Thank you so much. And I also wanted to take our attention back to Susie, who's been patiently listening to us online. Do we have some time to hear from Susie? Susie, you have 2 minutes. Sorry about that.
Thank you so much. Just some quick reflections on the very interesting and important discussions. So I think the reason that we're all here today is because we think that health systems are at the forefront of climate response, but they have been neglected in the global climate discourse. But we've been hearing just how important they are. So the Ebola and the COVID outbreaks that Lawrence and Carol talked about, I think really underline how critical it is for health systems to be able to connect and genuinely work with grassroots communities and leaders and frontline health workers, because they are the people who act first and who learn fastest about local risks and needs across sectors, because health, as we've heard, is not just about health facilities. Dorothy illustrated that very clearly in Uganda. Partha underlines the importance of water security. We can't build sustainable climate resilient health systems that can respond to these increasingly unpredictable challenges unless we work collaboratively and co-produce evidence, as Charles was saying, with those frontline communities and health workers. And they naturally work across sectors. People don't live in silos. And I'm a researcher. As researchers, I think we have an obligation to research and share information on the best ways to facilitate that kind of collaborative working, develop some of the tools Charles was saying are lacking. And our thematic working group on climate resilient health systems at Health Systems Global provides one platform that brings together researchers, practitioners, and policymakers together to promote awareness of the importance of health systems for climate mitigation and adaptation, and to share evidence and to encourage partnerships so that we can build climate resilient health systems and keep health systems at the center of climate policy and funding decision-making. So I'd really like to thank all of our speakers for sharing their insights from the ground, and wish this conference well in their deliberations. Thanks very much.
Yeah, thank you so much. And yes, thank you to all the panelists and the audience here as well and online. But I would like to see if our COP2nist is still online. And is there something you would like to show us from our talk, actually? Really looking forward to this.
Thank you, Tabenda. I've been really enjoying being a fly on the wall and listening to all of your very insightful contributions. Quick, here are my cartoons. This is what Tabenda opened the discussion. This one's from Dorothy's Reflections. I'd like you to take a careful look at what the different entities are labeled as: local health systems and climate resilient healthcare. Hopping over to the third one, based on Carol's inputs. And here's the final one, which I just thought is for all of us to just, enjoy a good laugh about. That's it from me. Tabenda, if you could just let me know which two of the four ones have been popular based on audience reactions. I can go ahead and furnish the 2 cartoons that I'm required to submit at the end of the. Thanks.
Which one definitely had the largest number of votes?
I'm sorry, which one?
The last one.
The last one.
And
right,
Amanda
okay.
will get back to you about the second or first
Sure.
runner-up. So thank you so much for everybody online. It's been different time zones for everybody, so we realize that. And I just want to thank you for being there, and thank you for this. The discussion is now open for questions. Sorry, I forgot about that. Yeah, but we really don't have a lot of time. But if there are any burning questions, we still have our panelists online and here. Yes, please.
Good day, everyone. My name is Abdul Basit S. Mikael. I am from Nigeria. I am one of the Youth Advisory Council of Comic Relief US. So my first question would be, I am interested in the intersection between climate change and health, and I'm so excited to hear that there are a lot of approaches that has been taken. What I want to know more about is, what are youth-led initiatives in this aspect? How are youth-led initiatives are contributing to ensuring that health are addressed and the impact of climate change are well addressed and connected to climate change in grassroots community particularly? And the second question I have is to one of the panelists here. He talked about policy I am from northern Nigeria. So, and there's this emerging issue in northern eastern part of the country regarding insecurity, which result to so many people being in IDP camps. And being in IDP camps, you know, most of the IDP camps we have, especially in Africa, am I allowed to generalize, are mostly temporary, right? And these temporary facilities, you will find out that they are prone to climate and environmental crises such as flooding, and the places are very congested. So are there policies on ground to ensure that the buildings, since now the buildings are mostly temporary, expecting the people there will live in a short time, but the climate change keep exacerbating, the insecurity keep exacerbating. So are there policies to ensure that those infrastructures are well improved, and are there particular funding or policies that are there to ensure that those things are improved?
Okay, thank you. So any other questions so that we can club them together? Are there any online? Okay, so let's, I think this will be the first and last question. We've already talked so much. I'll take the first question, and also from online, anybody who wants to talk about it. Thank you for bringing youth into the conversation. They're never divorced from it. As I said, taking a life cycle approach from school and out of school children as well, all the way through their adolescence. You know, one of the things that we saw in Pakistan was that many young people had to stop their education, you know, when their areas were affected. There was a lot of internal migration and different kind of psychosocial effects of that also. In fact, one of the districts, Tharparkar, that we were working in Pakistan saw a rise in the suicide rates of young girls, you know, because of the child and forced marriage phenomenon that became more common, and this is documented in the news as well. So we work with youth groups, community-based organizations, which have a large youth, you know, a large chunk of them as youth. They're climate activists and champions, and then also with the government systems where they have youth representatives, you know, for the communities, the local bodies. In Bangladesh, we work with the Youth Advocacy Network for climate change as well, to see how, you know, the concerns of the young people can also become, and in fact, they can be on the forefront. You know, at that time, it's the young people who need to take things in their hands, and they need to be contributing into the policy frameworks as well as agents of change. But if any other panelist has anything else, we can come back to them. I would just hand over to Charles right now on the second question around policy.
Yeah, thanks, thanks a lot. That's a very timely question. In fact, last week in Kenya, the Global Network on Disaster Risk Reduction for the Civil Society and UNOPS, they were in Kenya doing consultations around displacement induced by climate change, and we were in the northern part of Kenya, Turkana, and there is the Kakuma refugee camp. And the experience that I have had, especially in the refugee camp systems, is that we are looking at displacement largely from physical insecurity. But there is already, from the engagement with the civil society and community-based organizations, we were engaged because we were one of the institutions which was invited as research, is that there is more internal displacements induced by climate change. And also the refugee camps that we have spread across Africa are also impacted because they are dependent on the natural the natural resources, now creating also more tension between them and the host communities. Now, in terms of policy response, I will say, yes, we have got the regional policy framework, but not sufficiently responding to this question around climate change impact on the refugees. Yeah. Because we are looking at it only from the physical insecurity or security. Thank you.
Thank you so much. Thank you for the patience of everybody outside as well. I would like to conclude our session today. And if you want to continue this conversation, you know who to reach out to, and outside in the networking area as well. So hope to see you there. Thank you, everybody online. I hope you have a great rest of the day. Bye.